Good evening, everybody. Welcome to 2024 and the very first Conversations with a Doc for this brand new year. We're really lucky to have Dr. Howard WEISS speaking this evening on personality changes and cognitive issues in Parkinson's disease. He is actually on vacation, but took time out to make sure he could be here today with us. So, Howard, take it away. Thank you, and thank you.
Well, thank you, Judy, and it's a pleasure to be speaking on behalf of the Maryland Association for Parkinson's Support and all the wonderful things this organization does. So today I'll be discussing cognitive issues in Parkinson's disease. And here's the outline of my talk this evening. I'm going to discuss normal aging, what happens to all of us more or less. And then I'm going to define something known as cognitive impairment, mild cognitive impairment. And I'm going to also discuss what is dementia. And I think this is a bit of a confusing topic for some people. I'll then review some of the specific aspects of cognitive decline that's related to Parkinson's disease, review how we treat these things, and I'll conclude with suggestions for the care partners of people with Parkinson's disease who are experiencing some of these problems. Now, I'm sure many of you watched the television show Jeopardy! It is really a terrific show. It's a great way of trying to enhance your own memory. But there's something very interesting about this show. There has never been a winner over the age of 60. Why is that the case? Well, there's two reasons. One is they've actually never had a contestant on regular Jeopardy over the age of 60. They did have something called Senior Jeopardy once, but the Jeopardy candidates have all been, the Jeopardy winners have all been under the age of 50. Why is that the case? Are they discriminating against older folks? Well, no, that's not the problem. The problem is that cognitive efficiency declines with aging. And of course, Jeopardy is a show that tests not only knowledge, but speed of response. And some of the common things that all of us will begin to experience in our late 60s and 70s and 80s is the fact that things slow down a little bit. We don't recall names, or we don't find words as quickly as we used to. So I'm sure you've all had the experience of seeing somebody you hadn't seen in a while and, what's their name? And then 5 minutes later, you might recall it. And most of us find that, gee, we might misplace things, we don't work as quickly, and certainly multitasking is a challenge. But yet, we remain competent. And these are symptoms that can occur in competent, healthy, older persons. But the good news is that even though our memory and our ability to find words real quickly so we can compete on Jeopardy, that may decline. But in some instances, people can age like fine wine. Because with age, we do experience wisdom. We do experience experience. We just have these things we've learned over the years that enable us to remain competent and vital. But there is a phenomenon that can occur that's a little beyond normal, and it's known as mild cognitive impairment. And so what is mild cognitive impairment? So persons with mild cognitive impairment may have these same issues, word finding problems, maybe take a little longer to remember, work a little slower, but it gets into the edge of normal when other people begin to notice it. Because most people who have these normal aging changes, we might be aware of it, but other people aren't aware of it. But sometimes these cognitive changes remain mild, but they become noticeable, a little greater than expected. But nevertheless, the person is able to function normally. So persons with mild cognitive impairment have a little extra memory impairment, a little extra problems with getting things planned or executive function, but they're not impaired. They still function normally. Now, mild cognitive impairment, the most typical symptoms in the general public are objective memory loss. Other people can actually sense that there's a little memory problem, but it's not that severe. And more difficulties with naming, word finding, maybe following directions. This can be the prodrome to Alzheimer's disease in some situations. But even then, it may be many years, 5 years, 10 years, even 15 years before the symptoms worsen enough to really fall into what we would call dementia. And in other cases, these symptoms may not worsen much at all. But mild cognitive impairment in people with Parkinson's disease is a little different than what we see in the general public. Because if persons with Parkinson's disease develop mild cognitive impairment, it often specifically affects executive function, getting things planned, getting things organized efficiently, impaired attention, not being able to focus as well, and in particular, something known as visual perceptual problems, which I'm going to describe on the next slide. But in the typical Parkinson mild cognitive impairment, memory loss and word finding problems are less prominent than in the general public with mild cognitive impairment. So what are these visual perceptual problems? You might, for those of you who are patients who've had Parkinson's, you might wonder, why does the doctor have me copy these funny geometric shapes or draw a clock? And this is one of the ways we test visual perceptual problems, because in persons with Parkinson's disease who have mild cognitive impairment, there's difficulty with drawing or construction. There's some difficulty perhaps in depth perception and spatial relations. And sometimes this could affect driving safely because people might have a little more difficulty staying in their lane or judging distances between cars. And in some situations, these visual perceptual problems cause what's known as illusions, where you may be driving down the street and there's a fire hydrant, but it looks like a little red man, or even sometimes having little hallucinations where you see something that isn't there and you blink and you realize it's not there. So these are some of the visual perceptual problems that seem to be more common in Parkinson mild cognitive impairment than in the general public. So how common is this? So this is just I took a study out of the medical literature, and there's been all sorts of studies, and the data is different in different studies, but just to give you a general idea, this was a prospective 5-year study of 178 people who had recently been diagnosed with Parkinson's. So these patients were studied every 6 months for 5 years, and at baseline, at the beginning of the study, out of the 178 people, 142 passed all these cognitive tests with flying colors and were judged to be entirely normal, but 36, which was about 20% of the group, were actually found to have this so-called mild cognitive impairment that I just described. So what happened to those patients with mild cognitive impairment over the 5-year period? Well, it's a bit of a mixed bag, because much to my surprise when I read this article, 8 of these 36 people, or about 20% or so, were actually normal after 5 years. They actually got a little better. They didn't go downhill. They actually got normal by the end of the 5 years. Another 14 or 38% or so continued to have mild cognitive impairment. They were still functioning normally, but a little more difficulty. And unfortunately, 14 of these 36 patients were actually declined to the point where they were felt to actually have dementia. So it was a mixed bag. And the reason I want to point this out is that in so many things in medicine and neurology, the prognosis is always not as predictable as we like. You know, if you go to the racetrack and you bet on the favorite, you're only going to win 33% of the time. You're going to lose 2/3 of the time. So even the most likely outcome isn't always the most common outcome. So it's very true that dementia is often preceded by a period of mild cognitive impairment. But I think the good news is that people with mild cognitive impairment don't always develop dementia. And this is something those of you who've been to my talks in the past have probably seen this slide before. But I have 2 types of patients. You know, I might ask a patient if they have a certain symptom or certain type of problem, and I expect them to say yes or no. But some people respond, not yet. And I always tell patients, life is not better if you think like a not yetter, because everybody doesn't get every symptom. The prognosis, it can be variable. So everything in medicine is a bit of a bell-shaped curve. And I think it's so important to maintain good mental health, a positive attitude when dealing with a chronic condition. So if any of you in this audience have, for example, mild cognitive impairment, it is certainly a risk factor for dementia, but it's not inevitable. Don't be a not-yetter. Try to maintain that optimism. So, as I said before, mild cognitive impairment can evolve slowly over years into dementia, but it's not inevitable. It's not always the beginning of dementia. So what is dementia? And I find that when I talk to families about this and talk to patients about this, there seems to be a misunderstanding of what is meant by the term dementia. So dementia isn't a specific disease. Dementia refers to a cluster of cognitive symptoms. Cognitive symptoms, think symptoms regarding thinking and behavior, symptoms that progressively, slowly worsen to the point where they impair the person's ability to function normally. And what are these symptoms? Well, the symptoms, there's a whole list of symptoms, and nobody has every symptom. And in fact, certain types of dementia have different types of symptoms, but the symptoms that might occur in some persons with dementia include confusion, disorientation, not knowing what day of the week it is, or not remembering birthdays or other significant events. Of course, in persons with dementia, memory loss is much more significant than what we see in normal people or people with mild cognitive impairment. Most strikingly is the fact that, unfortunately, when people develop dementia, they don't have poor judgment. They don't have good judgment. Their judgment is impaired. They don't make good decisions. Often patients don't have good insight. They don't really appreciate that they're having problems. So you might ask a person with dementia, "How's your memory?" "I'm not having any problems, doctor." They don't appreciate their own problems. More significant problems with talking, reading, word finding, loss of executive function, unable to plan events, forgetting doctor's appointments, repeating themselves over and over again, and in particular in the forms of dementia that can occur in some persons with Parkinson's disease, we can see very abnormal behaviors and some personality changes. So dementia just refers to these clusters of symptoms that slowly or progressively worsening over time. And Alzheimer's disease is the most common cause of dementia, but it's not the only cause of dementia. Dementia can occur, unfortunately, in many other neurologic disorders, including people with strokes and people with other neurologic disorders, and unfortunately, also including some persons with Parkinson's disease. But here's an important distinction. It's very important as a doctor and as a family and lay people to know the difference between delirium and dementia. So delirium refers to people who suddenly become confused over a period of a couple of days, acute confusion. And this is something that's often triggered by what I would call toxic conditions. For example, somebody with an overwhelming infection, severe pneumonia, they're not getting enough oxygen, so they can't think clearly. They become disorganized and confused, and may even become combative. Other kinds of infections. Certainly, certain medications can cause confusion. People taking too many painkillers or too many tranquilizers. There's a variety of metabolic disorders that can cause confusion, including electrolyte imbalance or problems with blood sugar or thyroid function, and certainly intoxications, alcoholism or alcohol intoxication, illicit drug use. So there's a whole list of these toxic conditions that can cause acute confusional states. Now, the confusion may be very severe, but remember, dementia is something that's slowly progressing over months and years, not something that happens over a couple of days. So in most cases of delirium, the acute confusion will gradually resolve when the triggering condition is eliminated. So if somebody has pneumonia and they're being treated and their oxygen is better, suddenly they know what day of the week it is again. They return to their baseline. And of course, if the baseline wasn't normal, they're not going to, they're going to return to their baseline prior to the acute delirium. So it turns out that if somebody has dementia, if somebody is experiencing dementia and they get pneumonia, or they take too many painkillers, or they get intoxicated with something else, people with dementia are much more likely to have a sudden worsening of an acute delirium on top of their dementia. However, having acute delirium doesn't mean that you have dementia. And I've had certainly many colleagues who became very ill. They had a period where they were very confused and disorganized, and the treatment for their infection or their other metabolic problem was successful, and then they returned to normal. So dementia makes you more likely to experience delirium, but experiencing delirium can occur really to anybody. It does not mean that you have dementia. So over the years of my practice, I often found that sometimes cognitive impairment is underestimated by friends or family. And here's a typical scenario. A young man brings his father to the office as his son brings the father and says, I don't know why my mother keeps complaining about my father's memory and behavior. He seems pretty good to me. He's all right. I don't know what she's complaining about. And this is a phenomenon that I call hardy perfect. If you're not with the person very often, and you're just seeing them, let's say, at a little party or a social gathering, people with dementia might seem entirely normal. They can talk about the ravens, and they can talk about the weather, and make small talk, and it's all quite superficial, and they seem normal. Of course, go ask them, what's today's date, or who's the vice president of the United States? They may not be able to answer that, but making small talk, they seem fine. But of course, and this leads family or friends who don't spend that much time with them to suspect that what's the wife complaining about? Her husband's fine. They think that maybe she's exaggerating or making up stories. And this is it's more common than you think, that the people who aren't with the patient on a regular basis don't appreciate the degree of confusion, and confusion and dementia can wax and wane to some extent, and often patients seem quite nice in informal, casual settings. On the same token, and this is very common in people with Parkinson's disease, that cognitive dysfunction can be overestimated in persons with Parkinson's disease. So what am I talking about here? Oops, wrong slide. There we go. So we all know that slowness is a major feature of Parkinson's disease, particularly slowness of movement. Most persons with Parkinson's realize they just don't move their hands or their body as quickly. And that's you've probably heard your doctor use the term bradykinesia, slowness of movement. And that is one of the major motor features of Parkinson's disease. What isn't as widely recognized is the fact that slowness of thought, or what's known as bradyphrenia, can also occur in persons with Parkinson's disease. So what I mean by slowness of thought or bradyphrenia, if someone has bradyphrenia, there's often a lack of spontaneity. They may just sort of sit there and really not initiate much conversation. And maybe years ago, they used to be a raconteur, and now they're just sort of sitting there not saying much at all. So there's this lack of spontaneity. And then there's this slowness of information processing, and often particularly striking delays in answering questions or responding to questions. And sometimes these symptoms can be pretty mild, and sometimes it can be quite dramatic. So there's a whole scale of severity of how this bradyphrenia affects people. And it turns out that in persons with Parkinson's disease, there seems to be a fair correlation between the degree of bradykinesia and the degree of bradyphrenia, namely that the people who have the more slowness of movement are more likely to have more of the slowness of thinking. And here this little video shows a woman, she said how slowly she's moving her hand, so she would be more likely to have slowness and lack of spontaneity. And it turns out that people with Parkinson's who have prominent tremors but not much bradykinesia are just a little less likely to have bradyphrenia. But here's the rub. Bradyphrenia is very, very common in people with Parkinson's dementia. But there are many persons with bradyphenia who are not demented, and the slowing can be disproportionate to the general level of cognitive performance. In other words, these people are sharp, but they're just slow. But yet, unfortunately, people think because they're slow that they're not as sharp as they really are. And bradyphenia is tremendously demeaning and frustrating to the persons who are experiencing it, because here's what happens. If you're bradyphrenic and you go to a party and everybody's talking, you may never get a word in edgewise because you may know a lot about the topic they're discussing, but because you can't organize your thinking, people are talking a mile a minute and you never get a chance to say what's on your mind. And this is very demoralizing and belittling to people who have this phenomenon. And often I find that patients with bradyphenia they don't want to go to parties, they don't want to socialize, they don't want to interact because they feel like they're being ignored or they just can't participate. And this is a topic that doesn't get enough attention in Parkinson's disease. And I've always urged my colleagues when I speak to doctor groups, you have to explain bradyphenia to patients and their care partners and explain that bradyphenia doesn't, it's common in dementia, but it doesn't mean that you have dementia. And that we must allow the person more time to respond to questions and give them a chance to participate just for their own sense of worth, really. And in particular, I would often have to remind the spouse or the caregiver, please give the person more time to answer questions. Don't answer questions for them. Bradyphenia doesn't necessarily mean that they don't know what's going on. Now, another common phenomenon affecting behavior and cognition in Parkinson's is also rather subtle. Many of you who've had Parkinson's for a number of years probably realize that the carbidopa-levodopa medicine, which you take to help you move better, is really quite effective. But after a number of years, the effect may wax and wane during the day. So there may be times when it's working quite well, but there may be other times when the medicine isn't working quite as well, and you might move more slowly or might have more gait problems or more tremor problems, what we call these so-called off reactions in Parkinson's disease. And this is a common problem, and there's ways to try to minimize this. But what is less well understood and discussed is the fact that patients are having these so-called on and off spells. This can also affect cognitive and behavioral symptoms. And indeed, many persons who have what are called off spells when the levodopa effect isn't quite as robust creates tremendous anxiety, and people can even have panic attacks when they're experiencing these off spells. This can affect mood. Even patients who aren't depressed can feel very despondent during off spells. And there's cognitive symptoms. The bradyphenia will worsen dramatically in some persons with Parkinson's disease when they're off and improve considerably when they're on. And patients often use the term brain fog. It's really not a medical term, but I've heard so many patients use it. It's just a common symptom in Parkinson's in patients who are having these sort of non-motor fluctuations where there's more slowness, there's more bradyphenia, they can't get the words out, there's decreased verbal fluency during these so-called off spells. And these can be treated. Once again, this isn't indicative necessarily of dementia, although obviously persons with dementia might have these types of symptoms as well. But the treatment here is try to minimize these off spells, and there's many things that can be done in combination with your physician to help reduce not only the motor off spells, but the so-called non-motor off spells. I know the fluctuating symptoms, both motor and non-motor fluctuations in Parkinson's, can be very difficult for the family and the care partners to understand because it seems so illogical. How come dad could walk pretty well at 10 p.m., but he couldn't walk at 9 p.m., or sometimes the tremors minimal at 7 a.m. and bad at 9 a.m. It just seems so illogical. And I've had trouble convincing some families that this isn't misbehavior on part of the patient. This is what's physiologically is happening. And I think when families understand it, they can deal with it better, and certainly the patient can deal with it better. So what about Parkinson's disease dementia and what's called dementia with Lewy bodies? And there's an overlap really between these different disorders, Parkinson's dementia, Lewy body dementia, and unfortunately, having Parkinson's disease doesn't immunize you against getting Alzheimer's. So as we all get older into our 70s and 80s, the risk of Alzheimer's also increases and sometimes does occur in addition to just having Parkinson's. That's a real double whammy. So what is this dementia with Lewy bodies? You've probably heard of that term. So it turns out that there's a small subset of Parkinson patients who unfortunately already have dementia at the time the Parkinson's disease was diagnosed. In other words, that in a small percentage, dementia is occurring prior to or within a few months of developing the motor symptoms of Parkinson's disease. That's called dementia with Lewy bodies. The more common scenario is what's called Parkinson dementia, where people have Parkinson's for a number of years and then years later develop dementia. So but the symptoms of these two disorders are similar, but they're different than Alzheimer's disease. So how do we distinguish this Parkinson dementia from, let's say, Alzheimer's disease? Well, it turns out that in Alzheimer's disease, the short-term memory is really, really very poor, and it turns out to be not quite as affected in people with Parkinson dementia. The memory is not certainly by no means perfect, but it's better than we would see in people with Alzheimer's disease. And language function, often when I would test people, I'd show them pictures of different objects or names of famous people, and that's fairly good in people with Parkinson's dementia, but usually fairly bad in people with Alzheimer's disease. However, in people with Parkinson's dementia, and dementia with Lewy bodies, there's a much more common likelihood of experiencing visual hallucinations. People with Parkinsonian disorders, of course, have this so-called REM sleep behavior disorder that rarely occurs in Alzheimer's disease. And of course, REM sleep behavior disorder, that's that condition many of you probably know of, where people during deep sleep can sort of act out their dreams and begin to maybe holler and kick and maybe even fall out of bed. That can occur in almost anybody with Parkinson's disease, but you'd almost never see that due to Alzheimer's disease. Bradyphrenia is, of course, common in Parkinson's dementia, but not usually. The Alzheimer patients aren't that slow. They may answer questions more quickly, but of course inaccurately. One of the real hallmarks of dementia with Lewy bodies and Parkinson dementia is how the severity of cognitive impairment can fluctuate, that it can be very poor for several days, and then for a few days, the patient seems much sharper. It's almost like they're going in and out of little periods of delirium that for no obvious reason, whereas the Alzheimer patients don't show that kind of fluctuation. And of course, people with the Parkinson dementia and dementia with Lewy body have motor symptoms, so-called Parkinsonism, whereas that's really not the problem in Alzheimer's disease. So sadly, for people who have Parkinson's dementia for decades, it does affect a substantial number of people over a long period of time. Perhaps risk factors include being older when you get the Parkinson's. Once again, the akinetic rigid patients are more likely to be bradyphrenic, and that sometimes is associated with more increased likelihood of dementia. And having hallucinations certainly is also sort of a risk factor for getting dementia later on. So in Parkinson's dementia, we have this list of symptoms that is a little different than Alzheimer's disease. Psychosis, this hallucinations and delusions that I'm going to discuss in a moment. I haven't mentioned apathy, but apathy is a tremendously common symptom in Parkinson's disease, both in patients who are demented and patients who fortunately aren't demented, but it's just, there's often a lack of motivation, a lack of curiosity, a lack of interest, and that can be a symptom associated with depression. Apathy and depression can occur together, But apathy can also occur by itself in persons with Parkinson's disease, where there's just no motivation, no desire to do anything, yet the patient really isn't unhappy. They're just inactive and couch potatoes. We talked about the bradyphrenia, mood changes, and we'll talk now about some of the behavioral changes, the fluctuations in symptoms. But when somebody is experiencing dementia, the holes, the difficulties in thinking are like the holes in Swiss cheese. As the disorder advances, the holes, the difficulties become larger and more significant. But the rate of change can be highly variable. Sadly, there are some patients who, when they develop dementia, will go downhill rather quickly. But in others, it can be a more protracted situation where they do fairly well and compensate fairly well for a reasonable amount of time. So it's not, once again, it's not as predictable as one might think. What about the hallucinations? Very common. And there's two major types of hallucinations, what I call mild to moderate and severe. Because in many people who are hallucinating, they may walk into a room and they may see something that's not there. For example, they may walk into a room and, oh my gosh, there's a person sitting in a chair, and they blink twice and there's nobody there, and they realize, gosh, that really wasn't there. Or they may see a little cat outside their bedroom window, and oh, he's not really there. But then in other cases, there are severe hallucinations where they see that person sitting in the chair and it seems so real that they'll call the police or they'll start yelling at them. Well, fortunately, the mild to moderate hallucinations are more common than the severe, but you can see how disruptive a severe hallucination could be, because you can't convince the person that it's not really there, and they'll act accordingly. Now, it turns out having hallucinations doesn't mean that you're having dementia in Parkinson's disease, because unfortunately, some of the medicines that we use to treat Parkinson's disease, particularly the dopamine agonist drugs, but also amantadine, trihexyphenidyl, and even occasionally carbidopa-levodopa, if people are taking too much, can actually cause or accentuate visual hallucinations. So we have to realize that hallucinations can be a side effect of the medications in people who don't have dementia. But I want to emphasize, because this question has come up many times in my practice, do the Parkinson medicines cause dementia? Absolutely not. But can they aggravate dementia if not used properly, or if people take more than they can tolerate? Absolutely, yes. So the medications can aggravate or worsen hallucinations or cause hallucinations even in people who aren't demented, but they're not the cause of dementia. Sadly, one of the most severe symptoms in Parkinson dementia are what is known as delusions, where people get these bizarre false ideas that people are doing things or things are happening that are not really happening. And these are the three most common ones. And unfortunately, probably the most common delusion is what's called spousal infidelity. I've seen patients who've been happily married for 48 years, and the patient whispers to me, "Doctor, I'm so shook up. My wife is running around with the mailman and having an affair." And then I'll say, "Well, are people stealing your money and also plotting against you?" He said, "How do you know?" You know, these are the typical three delusions that can occur in people with Parkinson dementia. Very, very disruptive. I mean, you can imagine how this is so sad when the spouse is accusing another one of infidelity and accusing the plots of stealing things. So these severe kinds of delusions require treatment, which I'll mention in a moment. But there's another thing that makes life so frustrating for people who love and care for the person with Parkinson's disease, and that's what's known as empathy deficit disorder, where many patients who have Parkinson's disease and have dementia, because they don't really understand what's going on or how their behavior affects others, they don't even recognize their own need for care. So they either refuse care, or they don't seem grateful, or they're very negative, or they fight getting care, and they really can't appreciate the sacrifices that others are making. So how do we treat this difficult situation? Well, the first principle, of course, is avoid over-medication, avoid polypharmacy, using too many medications. So if you have Parkinson's, of course, you need to take some carbidopa, levodopa to control your motor symptoms. You have to be able to get around to the best of your ability. But we want to reduce the Parkinson medicines to the lowest dose needed to control symptoms, maybe eliminate unnecessary medications. But very importantly, if somebody has dementia, they should be given the pills by their spouse or their caregiver. Patients shouldn't be self-medicating because mistakes can certainly be made. And in particular, if persons are being over-medicated, it may make their confusion worse. And if they're being under-medicated, it may make their motor symptoms worse. So certainly not allowing people to self-medicate is important if indeed there's significant confusion. Avoiding the polypharmacy and avoiding other non-Parkinson medicines that can cause confusion. For example, no narcotic painkillers. If somebody's in pain, let's try to get by with Tylenol or non-narcotic medications. Avoiding tranquilizers, avoiding sleeping pills. There's a whole list of medicines called anticholinergic medicines that includes certain antihistamines, which can cause confusion. And certainly restricting alcohol intake to a minimum or eliminating entirely would be important. Is there anything else we can do? Well, as most of you know, the motor symptoms in Parkinson's disease are in part due to a lack of a chemical called dopamine, and the carbidopa, levodopa, and the other medicines help replenish that, and they're very helpful. Well, there's other neurotransmitters that are depleted in other areas of the brain, including something called acetylcholine, which is very involved with processing memory and cognitive functions. And there's a medicine called rivastigmine that can replenish acetylcholine to some extent and help improve these cognitive impairments and reduce the confusion in people with Parkinson's dementia. And my own experience with this drug has been that there have been some cases where it's been very helpful, and other patients where it wasn't quite as helpful, but it's definitely worth trying. And sometimes it also will reduce hallucinations. The rivastigmine can be given orally, but it has a high risk of causing nausea and upset stomach. Unfortunately, there's also a little transdermal patch where this little medicine patch is put on the person's back or arm, and the medicine can be given that way with less likelihood of having nausea. Now, if sleep, there's so many sleep problems that occur in Parkinson's disease, but there's no question that if we can improve nighttime sleep in persons with Parkinson's dementia, that we can reduce confusion to some extent. And this is, of course, it's easier said than done, but obviously having a nice routine where people go to bed at the same time, keeping them up a little later. So no sleeping after dinner, because if you sleep after dinner, you're certainly not going to fall asleep at 10 o'clock at night very well. A comfortable environment, avoiding alcohol and caffeine in the evening. But certainly I tell patients, if you're going to watch TV before bedtime, make sure it's something that's not upsetting. You don't want to watch violent shows at bedtime that are going to give you violent dreams. And don't watch the news where people are shooting each other or showing wars around the world. So if you're going to watch TV at bedtime, watch the Home and Garden station or something that's not going to get you upset to overstimulate you. Very importantly, I talked briefly before about these on and off times affecting motor function and behavior. Working with your neurologist to reduce off time during the night can be very helpful in improving nighttime sleep, and that's something that sometimes neglected. And if people are having very frequent REM sleep behavior disorder, treating that can also be helpful. Oops. So I said a moment ago that in patients who have really severe hallucinations or these terrible delusions, these are the patients who actually need to be treated. And of course, the first line of treatment is to try to reduce medications. But if the psychosis, if the delusions and hallucinations persist, then there is a role for antipsychotic medications. I've mentioned on this slide the three medicines that are used. these are not panaceas by any stretch of the imagination. And there's certainly dangers associated with using these antipsychotic drugs, but severe psychoses require some type of treatment in order for the patient to stay at home successfully and avoid institutionalization. Some of the standard antipsychotic medicines used by psychiatrists will actually have a risk of worsening of the Parkinson's disease motor symptoms and should be avoided. So these three drugs, quetiapine, clozapine, and pimavanserin, are the ones that at least we can try with safely realizing that we're not going to make the Parkinson motor symptoms worse. Sometimes they're helpful, sometimes, unfortunately, they're not as helpful. And I toss this slide in because it's so important for all of us, whether you have Parkinson's disease or not, to have advanced directives, letting your family know what you want to do if in the case of some type of medical catastrophe, because failure to plan often leads to futile, aggressive care by default and family discords about what should we do for mom or dad, and knowing their wishes before there's dementia, before there's a crisis, can avoid some of these family disputes. Well, I'm going to conclude with perhaps the most important topic, and that is, what about our poor caregivers? Who cares about the caregiver? We expect the care partner to be Wonder Woman or Superman, but none of us are Superman or Wonder Woman. Here's a typical scenario that I would hear from the spouse of a Parkinson patient. I knew that hiring someone would help made sense, but I didn't want to do it. Nobody can provide better care for my loved one than I can. Well, that's probably true, but it's not helpful. We have to acknowledge sometimes we need help. And then, of course, at first I resented Parkinson's disease, but now I'm beginning to resent my spouse. That's certainly something we want to avoid because we're human. And we all have our limits, and we all can get burnt out. And these denial, anger, social withdrawal, anxiety, depression, guilt, sleeplessness, fatigue, irritability, feeling overwhelmed, all these things are experienced by so many care partners and spouses of people with Parkinson's disease, and they could be avoided. But one thing, before I give my list of suggestions on how to avoid these problems, you're always going to find another family member or a friend who gives you advice. Why don't you do this? Or why don't you go there? Or why don't you do that? You know what? They're missing the point. When people are in distress, if people are sinking, if you saw somebody sinking in a swimming pool, you wouldn't yell, "Hey, did you think about swimming lessons?" No, you'd toss them a life preserver. People need help. If you want to really do good, giving advice doesn't get very far. Give help. And sometimes advice is well-meaning, but people need help. So what can we do to ease the strain of being a care partner? Well, I've had so many patients who had families and they'd say, well, gee, my son and daughter, they're both working real hard, but they're free at certain times. They said they'd like to help. You know what? And they would like to help. But don't be afraid to ask them. And in particular, hey, they're planning on working on the weekends, say, maybe ask your son, why don't you come over every Saturday from 10 to 2 and take care of dad, and so I can go shopping or visit my friends or have a little blah, blah, blah. Enlisting family members to assist on a regularly scheduled basis, not just when it's convenient for them, because, you don't want to be a bother. Be a bother a little bit. You'd be amazed how people want to help, but if you don't ask, they may not be volunteering. Of course, hiring aides for several hours on a regular basis is also helpful if it can be afforded. And I realize aides are really expensive. Family members are usually free, but don't be afraid to hire aides. People save for a rainy day, but when it's raining, sometimes you got to spend some money. Participation in exercise programs. Now, I'm not talking about exercise programs for the patient. The Parkinson patient, of course, should have been exercising, but exercise for the care partner is a great stress reliever. It's a great way to reduce stress and anxiety without taking tranquilizers. So you yourself, if you're a care partner, should be exercising, taking nice walks, getting in exercise classes. Of course, participating in educational seminars and support groups, very, very helpful for care partners, because I've always found that care partners learn more from each other, from other people going through similar situations than they ever have learned from me or other medical professionals. So, and the Maryland Association for Parkinson Support, and there are other organizations that do sponsor support groups for care partners. Very valuable, very helpful. Psychological counseling, once again, not for the patient, for the care partner. How do you cope? You know, and whether it's pastoral counseling or a social worker or a psychologist or even a psychiatrist, very important to help cope better. Something that's often neglected also is what's called a home safety evaluation. There are occupational therapists who will come to the house, come to your house that's covered by Medicare, and look around. Are there safety features that will make life easier for the patient and for you? Are there things in the bedroom that will help the patient get in and out of bed better? Are there things in the bathroom to make it safer to reduce the risk of falling? So this home safety evaluation by a professional is a much better idea than just buying a bunch of equipment to yourself that you don't know whether it's going to be helpful or not. There are adult daycare programs where, once again, these things can be pricey, but where patients can get out of the house for a few hours, giving the spouse or the care partner a little chance to have some free time for themselves, and the patient gets a little entertainment and activities. But last but not least, do something nice for yourself every day. Don't forget yourself, and do not drop out of the mainstream of life, because that's just going to make you miserable, and it's certainly not going to help your spouse or your loved one. So I hope I hit on some points that were informative and helpful. I think Judy might have some questions. How are we doing time-wise? Are we doing okay?
Yeah, we're okay.
So anyway, thank you for being here, and I hope this was helpful to you.
Okay, first question was in the chat. If I can read it. What treatment or drugs are available when the person is diagnosed with mild cognitive impairment?
Yeah, so that medicine rivastigmine that I mentioned briefly on the slide is helpful for patients who have Parkinson's dementia. And surprisingly, in the studies, it didn't seem to be that helpful for mild cognitive impairment per se. So that surprised me. But I guess it indicates that mild cognitive impairment is mild. And I think keeping engaged in the mainstream of life, you know, participating in social activities, reading magazines, reading books, you know, I think keeping active mentally is probably the best exercise you can do for mild cognitive impairment. We always talk about exercising your body and getting into boxing classes and walking and treadmills, but exercising your mind, I think, is probably the best way of treating mild cognitive impairment rather than taking more medications. Now, you see on TV, and I always get a kick out of these ads, Prevagen and Arriva, and I know many patients will probably try those things. And I've never come across anything that shows that they were hurting anybody. But whether it really makes a difference in helping, questionable. But I know people will try those things. I never discourage people from trying things that might be safe, but I realize that it might be a waste of money, and if they don't see benefit, there's no reason to waste the money on it.
How much do you push your partner with apathy to continue to socialize with friends and family?
Oh, wonderful question. So by definition, the apathetic person is not motivated to do anything. Yet, in most cases, if the caregiver or the spouse makes plans, okay, honey, we're going to go to the symphony tonight. They may say, I don't want to go, but they will go. If plans are made, they usually will go along for the ride. And more often than not, they may even enjoy it. But they're not going to make the plans themselves. So if you enjoy going out to dinner with friends or going to the symphony or going to your or going to church on Sunday or whatever, you're going to have to push the patient. But more often than not, they will go. They're not going to say, I want to go, but they'll go along for the ride and they'll usually enjoy it. So that is really the treatment for apathy, is that somebody has to actually organize and make plans, and because the patient's not going to get up and go without being pushed. And it's really frustrating for the family because, it's a lot of work for the family.
Let's see, can you define and provide symptoms of mild cognitive impairment? I think you did that earlier in your talk.
I'll do, yeah. So once again, I said, as we get older, all of us, for example, find that, gee, we don't remember names quite as quickly. It takes a few minutes to get a name out or get a word out. We can't multitask as well. We're just not as organized. We're not as efficient. And often these are things that you realize yourself, but other people may not even notice it. Mild cognitive impairment really is a little more than that sort of normal aging process where other people begin to notice, gee, he's not getting his work done so well, or maybe he's a little more forgetful than most. So it's something that's objective to others. So how do we diagnose it? The physician will more likely diagnose it if let's say the spouse comes in and mentions these problems, because the patient may not even be as aware, and yet the problems aren't severe enough to interfere with daily activities. So if you're still working, yeah, you can still get your job done. Just take a little longer, maybe a little less efficient. Maybe you have to check it twice, but you'll pay your bills, but it'll take a little more effort and work as opposed to, let's say, somebody with dementia who might forget to pay their bills altogether.
What's a good reference on Parkinson's that is current, complete, and geared to the average person?
Wonderful. So there's a book called by a friend of mine from Mayo Clinic, Dr. Alskog. His last name is Ahlskog. Dr. Eric Alskog wrote a book, and it's probably 600 pages long. It's called the Parkinson Treatment Book. I'm trying to see. I'm having a little mild cognitive impairment. It's Eric Alskog, the Parkinson Treatment Book, and it's not a book that you would read from cover to cover. It's almost like an encyclopedia of everything and anything that Parkinson patients might experience. But it's the kind of book that you would read. Let's say if you were having trouble sleeping at night, he'd have 30 pages or 20 pages on how to improve sleep. Or if you have any questions about side effects or how to use medicines properly, but it's written for the lay person. Dr. Alskog is a wonderful doctor and a wonderful writer. It's written in very simple, easy to understand English, but it's a big book. And once again, you're not going to read it from cover to cover, but you'll read it if you're having a certain problem. He'll address that in simple, easy to understand terms. So that's the book I've recommended over the years. Eric Alskog, the Parkinson Treatment Book, and the nice thing about Dr. Alskog is he's not pushing any particular drug or product. He's a very honest guy.
Okay, and here's some of the questions that were submitted earlier. Are there any therapies or medications that can assist with the constant confusion, hallucinations, and mood swings that plague my father? We have tried Nuplazid, but it's so hard to know what and how this is affecting him.
Yeah. Yeah, and of course, and that's a real issue is how how do you know if the medicine's working? If things get completely better, of course it's working, perhaps, but how do you know if there's even a partial response? So when you're using any of these medications, you want to before the doctor starts the medicine, you have to say, well, what are the target symptoms I'm hoping to address? So, for example, if somebody's having hallucinations, are the hallucinations the same? Are they getting better? Are they getting worse? So those three antipsychotic drugs I mentioned, the including the Nuplazid and the pimavanserin and the quetiapine and the clozapine, all three of those are more effective, for example, for helping reduce hallucinations than they are for reducing delusions. And so often patients also might have some depression that needs to be treated. And once again, persons with dementia are less likely to benefit from talking to a psychologist because they might not really remember what was said 10 minutes after the session. So often medications have to be tried. And once again, so we have to look at what are the target symptoms. Is it helping appetite? Is it helping sleeping? Is it helping mood? But Judy, sad to say, there really aren't enough doctors trained to treat patients with Parkinson's dementia because you need somebody who's both a neurologist and a psychiatrist, and 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 somebody who's really familiar with all these different nuances. So it's very hard to find the right doctor who has all those different talents. And even when you do find that doctor, the medicines and our treatments are often less than adequate. So it's a very tough situation. Uh,
Well, hard answer.
but
Um,
no, but the reality is, but it's not a hopeless answer because there's always a little bit of trial and error, and so the answer is there is some help, but it's often takes several trials and before you get the right combination.
okay, here's another question. This is a longer one. I was diagnosed at Hopkins with PD this year at age 63. After 5 years of being told that my left arm tremor and weakness was a result of C5 and C6 spine damage from a car accident. My 90-year-old mom has spinal stenosis, which she was told has caused her right arm and leg weakness, requiring a power wheelchair for mobility. She has also suddenly developed the inability to void bladder or bowels and she has panic attacks. She
Mm.
is in subacute care following a hospital stay for back pain and inability to void. So here's the question. How might someone who is confined to a nursing home obtain a synuclein biopsy like I had, or a video visit with a movement disorder specialist? And then there's a second part here. Could Parkinson's treatment make any difference in such symptoms at this late point?
So it's a very complicated question, and I'm not going to answer this. I mean, it's too specific. But let me give a general answer to this very difficult specific question. Over the years, I would occasionally see patients, particularly very old patients, who had symptoms that might be Parkinson's, but might not be Parkinson's. And in some of these cases, we weren't able to get, and the synuclein biopsy is very new and still, not as generally available. And in the old days, there was no such test at all. And sometimes what I would do and other doctors would do would actually if we thought it might be Parkinson's, and I'm not sure this case sounds like it might be Parkinson's or not. The details are too vague, but in cases where I thought, well, is it Parkinson's or not, I actually would give a therapeutic trial of carbidopa-levodopa. And I would start with a small dose and increase it up several notches and see if the target symptoms improved. So if somebody was having shuffling gait and unsteady gait, and there's many causes for that besides Parkinson's, but it wasn't clear if the gait improved on the carbidopa-levodopa. I said, oh, wow, that's terrific, we'll continue it. And if it didn't help, we would stop it. And I would say over the years, I had several cases where it really made a huge difference for a very elderly person. And more often than not, it wasn't that helpful. But it's that type of empiric trial is sometimes worth doing. And there are I'm not sure who in our community is actually seeing new patients via telemedicine these days, if anybody. I'm not sure, Trudy.
Okay, here's another one here. Why would my neurologist want me to take 6 pills a day when they make me so nauseous? I have a mild tremor in my left hand and am very happy taking just 2 pills.
No. Okay, well, that's a good question. So that's a good question. First of all, there is no dose that's right for everybody. Every patient with Parkinson's disease is different. Some people need 12 pills a day. Some people need 2 pills a day. So I think it's something they have to discuss with their doctor. If 2 pills work, why take 6 pills? That's certainly, so it's something to discuss with the doctor. But the key here is that there's no standard formula that's right for every patient. It's a disease that's every case is different.
What does research tell us about exercise and movement disorders, specifically balance and gait issues?
Well, the studies that show where they have had patients with early Parkinson's who participated in vigorous, regular activities of exercise, whether it's cycling on an exercise bike or other types of exercise, boxing. And if you look at those patients who exercised versus patients who didn't exercise after 5 years and 10 years, the exercise group definitely is more mobile, more agile, moving better, walking better than the non-exercise group. And now studies are like that are somewhat biased because it takes motivation to participate in the study and do the exercises. But I always remind people that it's fairly easy to take pills, but exercising on a regular basis takes effort. Effort isn't always rewarded, but certainly lack of effort is never going to be rewarded. So I encourage patients to make the effort to try, because at least statistically, it gives them a better chance of functioning better after 5 and 10 years. But can I actually guarantee that it's helping any individual patient? I mean, statistically it helps, but can I actually tell any individual that it's helped you or not? That's a stickier question.
And I think, so another person asked, can you tell us more about hallucinations?
Yes. So it turns out that Parkinson's disease not only affects the motor system, it does affect the visual areas of the brain as well, and to a lesser degree. And that's why I mentioned that with the Parkinson's disease mild cognitive impairment, there's all these visual perceptual problems with spatial relationships and ability to solve little puzzles. Let me, if I go back to that slide here. So the visual system is affected. And it's not something that your eye doctor, you can go to your ophthalmologist, you'll have a perfect examination. It's not an eye problem, it's a perceptual problem. Let's go back to that slide here. Oh, here it is. So these symptoms reflect problems with visual processing in the parieto-occipital part of the brain. That's the processing part of the brain. Now, hallucinations are also part of this possible phenomenon. And people have actually studied very carefully, interviewing patients with Parkinson's disease, that many people who are just totally normal cognitively either experience mild hallucination, many might experience mild hallucinations, or there's a phenomenon known as a sense of presence. And that's the feeling like somebody's standing behind me or somebody else is in the room and nobody is there. A very common symptom in persons with Parkinson's disease who aren't demented, who aren't, over medicated. So So this is a phenomenon of Parkinson's itself. And then, of course, in those patients who are having those very mild hallucinatory phenomena, if you over-medicate them, the medicines might accentuate the hallucinations in the absence of dementia. So it's a very interesting area of Parkinson's disease, but just pointing out that Parkinson's affects much more than just the motor system. And the visual symptom is a little out of sync in some patients. And it's the processing, it's not the eyes, it's the processing part of the brain.
I think that's it. I think that's it for the questions.
Great.
I think that's it.
Great. Well,
Thank you so much. I
you.
think this was very informative, and you're so easy and good to listen to. So thank you. Thank you for taking your vacation time and doing this.
My pleasure. Always good. I wish good luck to everyone, and don't be afraid to I think with those who are listening, I think before you go to see your doctors, it's always good maybe to write down a couple of questions, because I know so many patients would tell me later, gee, I forgot to ask you X, Y, or Z. So, if I've raised any topics that you want to discuss with your doctors, just jot it down so you won't forget. You'll get the most out of your visit sometimes if you just jot down things that you want to review, and that this way you'll get the most out of your visitors with your doctors. So anyway, thank you, Judy, for inviting me, and good luck to all of you.
Thank you. And everybody who's listening, please fill out the evaluation form that Michael will send you at the end of this talk. It really is very important that we get those back. So thank you again for coming. And Howard, thank you for doing this. And now you can go back to your vacation.
Okay, my pleasure.
Thank you. Good night.